The third Caribbean Antimicrobial Stewardship Conference is brought to you by Biomerieux, Beckman Coulter, Radiometer, and Farmenpex.
Curaçao has become one of the Caribbean's top beach and water destinations. More than 35 beaches line the calm southern coast. In addition to private resort beaches, Curaçao has splendid public beaches with crystal clear water and amenities including food and drink. Some charge fees and offer additional services such as showers and dive gear, even massage. Perhaps most alluring are Curaçao's small, intimate coves and beaches. Beach connoisseurs can rent a vehicle, load a picnic, and create their own private escape. Curaçao's abundance of coral and shipwrecks in shallow and deep water makes snorkeling and diving extremely popular. More than 70 dive sites surround the island. In fact, Curaçao is named one of the best shore dive destinations in the world because of easy access to dive sites and visibility up to 100 feet. A popular day trip is the boat excursion to the uninhabited island of Klein Curaçao to swim with sea turtles and explore shipwrecks. Another excursion takes divers to the Blue Room, an underwater cave off the west coast. Closer to Willemstad, the Sea Aquarium Complex offers experiences centered on ocean research and preservation. The Dolphin Academy trains dolphin experts, while the Dolphin Therapy Center helps children with disabilities. Ocean Lens is an underwater observatory for visitors. Offshore, the Curaçao Underwater Park offers 19 dive sites, pristine reefs, and numerous wrecks. For a deep dive, visitors take Substation Curaçao to 1,000 feet below. Other favorite activities include riding the Aquafari underwater scooter and Sea Bob's powered underwater sled. Topside, visitors love wind and kite surfing and kayaking at Spanish waters, and riding the Zapata flyboard at Yontil Beach. Watch the Land Adventures video for experiences from rugged to refined. Curacao has a hot new vibe and is now the place to be. An explosion of art, architecture, and restaurants has spurred redevelopment, transforming Curacao into one of the hippest destinations in the Caribbean. But the island still radiates its European charm, natural beauty, and wonderful mix of Dutch, Spanish, Caribbean, and African cultures. Visitors must go and feel it for themselves. Located on the outer fringes of the hurricane belt, Curacao is easy to reach by nonstop flights from 6 North American gateways and by same-day service from 40 cities in the USA and Canada. Still a member of the Kingdom of the Netherlands, daily nonstop flights arrive from Amsterdam, and many flights arrive from South American and Caribbean locations. English is spoken widely, along with Dutch, Spanish, and Papiamentu, the local language. Curaçao's dry, sunny climate and an average temperature of 87 degrees Fahrenheit make it a mecca for every variety of outdoor activities. Visitors won't have to change money. While the official currency is the Netherlands Antillean Guilder, or NAF, US dollars are widely accepted. And the water is safe to drink, straight from a modern desalination plant. Want to know more? Watch our other videos to learn all the things you need to know for planning personalized dream vacations. You'll see where to stay, lounge, dine, and party. You'll get tips on the hottest areas like the Peter Mai district, the best beaches, where to access shore and ocean dives, and all kinds of land and water-based activities, some that are unique to Curacao. So, welcome to Curacao and its hot new vibe. Visitors must go and feel it for themselves.
When a patient's condition is unclear and diagnosis difficult, their health can be threatened by an unseen danger. Sepsis is a global medical emergency with devastating consequences. Each year, more than 20 million people develop sepsis. Of those, 30% or more die. That's more than lung, breast, prostate cancer, and AIDS combined. Sepsis is caused by an infection that can begin anywhere, anytime, when bacteria or other infectious microorganisms enter your body. It is difficult to identify and diagnose, especially in its early stages. Symptoms are often unclear and very unspecific. Consequently, sepsis is often overlooked or recognized too late. And the later sepsis is recognized, the more deadly it will become. The result? Too many people develop sepsis and too few survive. That is why Radiometer has joined the fight against sepsis. We want to build awareness around the importance of early diagnosis and to empower healthcare professionals with vital diagnostic tools. Radiometer is introducing Procalcitonin, or PCT, our new acute care assay to aid in the early detection of sepsis. As of today, PCT complements other testing recommended in sepsis guidelines. Early detection can reduce spending in the management of sepsis patients and will help save lives. Because the earlier sepsis is detected, the better the odds for a new beginning. Our mission is clear.
Fast, reliable blood gas results are important for any modern hospital or clinic that wants to improve the quality of their overall patient care. Speed and accuracy are paramount in any critical care setting. So the easier and simpler point-of-care testing can be, the better. Imagine if in just 70 seconds you could support your diagnosis by performing a complete blood gas analysis and receive reliable results using only 70 microliters of blood. Imagine that. That's what Radiometer's renowned engineers in the US and Europe did. Using proven thick film sensor technology, they reimagined the blood gas analyzer. how it looks, how it works, how you operate it. Every innovation was driven by the challenging ambition to combine chemistry, electronics, and mechanics in a clever and simple analyzer that would work in the hands of all healthcare professionals. What they have succeeded creating is a easy-to-use, reliable and robust, cost-efficient blood gas analyzer. Blood gas analysis is a sophisticated science, and there's no room for compromises when critical diagnostic decisions are required. Every feature must be carefully tested and modified to fulfill its full potential. The ABL9 is the product of dedicated and tireless engineering, a clever plug-and-play solution designed to improve patient care by simplifying the daily operations of healthcare professionals. ABL9 Analyzer. Clever, made simple.
Jag heter Anna-Karin Stålberg och jag jobbar som biomedicinsk analytiker på klinisk kemi här på Hallands sjukhus Halmstad. Har varit här i 10 år. Hallands sjukhus Halmstad har lite drygt 400 sängplatser. I en livshotande situation är det viktigt att patienten omedelbart får de hjälpinsatser som behövs för att kunna rädda hans eller hennes liv. För dem är det av högsta vikt att omedelbart kunna få en blodgas för att kunna ställa in behandlingen därefter. Jag valde det här yrket eftersom jag känner mig fascinerad utav teknologin och på vilket sätt man kan använda den för att hjälpa människor. Mina dagar består utav att analysera både blodgaser, men då även en stor andel kalciumionprover och pH i pleura. Som biomedicinsk analytiker så jobbar vi ofta som den osynliga länken mellan patienterna och vårdgivarna. Den apparatur jag arbetar med, den måste vara tillförlitlig, användarvänlig och driftsäker. Allt för att kunna säkerställa den högsta tänkbara kvaliteten på de resultat som vi lämnar ut. De snabba svaren gör det möjligt att omedelbart justera patientens behandling. Användaranvänligheten betyder väldigt mycket för oss. Under mer än 10 år så har vi utnyttjat Radiometers ABL 800-serie och den fungerar väldigt bra för oss. På plusversionen av ABL 800 Flex så har vi fått en betydligt finare touchskärm och processorn är mycket snabbare. Den är betydligt enklare att jobba med. Inloppsklaffarna och andra touchpoints är numera markerade med en klarblå färg. Eftersom jag vet att de provsvar vi lämnar ifrån oss leder till en omedelbar behandling så måste jag känna 100% trygg med det jag lämnar ifrån mig. Hade jag inte haft det så hade jag inte sovit gott om nätterna heller.
Good morning, good afternoon, or good evening, depending on where you're joining us from. Welcome to the third edition of the Caribbean Antimicrobial Stewardship Conference. We are so glad to have so many of you joining us from your offices, your labs, your hospitals, and whether you are connected by yourself or if you are following this seminar with other colleagues, thank you for investing this time in the fight against infectious disease. I want to thank the wonderful team of people who have worked and continue to work tirelessly behind the scenes to put this conference together in this new format. A special and heartfelt thank you goes out to all our speakers for their willingness to take the time to share and interact with us today on various topics. A sincere thank you goes out to our sponsors, for it is in this collaboration between industry and the front lines that we are able to leverage resources towards common goals. Lastly, thank you for being an engaged and active participant today. The Caribbean Antimicrobial Stewardship Conference is hosted by LabKnowledge and is made possible by contributions from various sponsors. LabKnowledge is an institute for continuing education and research in laboratory science and is fully funded by Pharminpex. 4 years ago, in a year-end debriefing following our travels throughout the Caribbean, I shared with my team the observation that there are a lot of good efforts going on in the Caribbean, specifically in the area of infectious diseases, antimicrobial stewardship, and infection prevention and control. But that unfortunately, there were not many avenues for this information to be exchanged among the countries and institutions of the Caribbean, and most importantly, between lab techs and medical practitioners themselves. I also noticed a real interest from all organizations to engage in continuing education and a commitment to fight infectious disease despite the lack of resources. These observations gave rise to the establishment of the Caribbean Antimicrobial Stewardship Platform, a LabKnowledge initiative in which the focus was to create an avenue for sharing knowledge, practical experiences, and best practices, promote collaboration between islands, organizations, and individuals in the fight against infectious disease, and provide the infrastructure to link not only global, but especially our local Caribbean experts and make continuing education initiatives more accessible. In 2017, thanks to a funding guarantee by Pharminpex, LabKnowledge committed to a 5-year cycle to host the Caribbean Antimicrobial Stewardship Conference. The first conference was held in Curacao in September of 2018 in collaboration with NASCO, the Dutch Caribbean Foundation for Higher Clinical Education. In October of 2019, the conference was held in Barbados in collaboration with Dr. Corey Ford and his team from Caribbean Infection Prevention and Control. This year, the conference goes online and is spread over 3 consecutive monthly live webinars covering the topics of sepsis, infection prevention and control, and antimicrobial stewardship. Last year in Barbados, I was very much inspired by the breadth of medical professionals from all areas of healthcare who felt the importance to engage in infection prevention and control. It led me to declare in my opening statement that together, we can create a world in which there are no more deaths from infectious disease. While this may seem like a bold statement, and while it may be true that the results may not come overnight, this vision of our future is still worthwhile. In a year where we face the challenges of coronavirus, it may be easy to feel overwhelmed or feel like this problem is too big to solve. Still, there is a lot to celebrate. I want to remind each and every one of you that you are an important piece of the puzzle. As a healthcare practitioner, your choices directly impact the lives of people in your community. Most of these people don't know you, or most of these people may not comprehend the role you played in their health and well-being. You may not receive the recognition you feel you deserve. Despite all this, choose to make a positive impact and choose to make a difference in the fight against infectious disease. We may or may not be the generation that will eradicate death from infectious disease. But if we all do what is within our reach to contribute, we will be the generation who made significant progress on this issue so the next generation can get a head start. And that is certainly worth celebrating. Enjoy the conference and above all, share, interact, learn, and commit to the action that is within your reach to create a world in which there are no more deaths by infectious disease. Thank you.
Thank you very much, Mrs. Diaz, and good morning, everyone. And welcome again to the third annual Caribbean Antimicrobial Stewardship Conference in 2020. Remember that this live webinar is hosted by LabKnowledge Foundation. My name is Germán Esparza. I'm clinical microbiology professor, and I am broadcasting from San Gil in Colombia. Thank you very much for the kind invitation to be your host this morning. This Caribbean Antimicrobial Stewardship is an effort of LabKnowledge with the support of main sponsors like Pharmimpex, bioMérieux, Radiometer, and Beckman Coulter. This is the first ever webinar session of mini-series with the topic of sepsis, what is the most biggest threat and challenges for patient care. And it's having a particular importance now that we face this COVID-19 pandemic. Today, we are going to hear a couple of good presentations from two experts in the field who will share with us their knowledge and personal experiences with biomarkers for sepsis. The use of biomarkers has been controversial, and the proper use of those tests will help us to strengthen our antibiotic and antifungal stewardship programs. Remember that you can type your questions in the chat room, or you can request to speak, and that option will appear on the right side of your screen. And now, it's my pleasure to introduce Mr. Nasser Ajubi, who is a big registered clinical chemist who has recently appointed as head of the Clinical Chemist Department of Analytical Diagnostic Center, Curaçao. He is a passionate laboratory specialist that has gained experience in diverse clinical settings while leading the clinical department of hospital laboratories on several Dutch Kingdom islands. From July 2019 until May 2020, he has worked as lab specialist at LabMed Curaçao. Until June 2019, Nasser was the director of SLS NV Laboratory in San Martin, and also overseeing the hospital laboratories of San Eustacia and Saba. Before moving to San Martin, he has worked many years as the head of the CEO's hospital in Curaçao. During his appointment at CEO's, he participated in a research which involved the use of Procalcitonin in an emergency room, which led to the first PCT publication in the country of Curaçao. He's going to present the conference CRP or Procalcitonin, what is your flavor? Please welcome Mr. Ajubi.
Thank you, Germán. Thank you so much for this very eloquent introduction. I am very honored to form part of this team, and I would like to share not only some recent data that I have found on the internet, but also some personal experience with some of these markers that we're going to talk about, which we've done some research, here in Curaçao. So I would like to ask the moderator if they can help me with the slides before we continue. Okay, so again, my name is Nasser E. Ajubi. Since June, I've been part of the Department of Clinical Chemistry and Hematology at ADC NV in Curaçao, which is the largest lab on the island, and it's also the laboratory which serves our brand new Curaçao Medical Center, which actually opened last November. So I have no disclosures, and I'm just happy to be part of this team, and hopefully I can bring you some new insights into the biomarkers that we will talk about. Next, please. So again, the objectives of this talk is to give a brief overview of sepsis and how the clinical laboratory in this case can aid the clinician in diagnosis and management thereof. Evidently, I will talk about what an ideal biomarker is in this particular setting, and which are the ones that are currently in use and which are the ones that are under investigation. And finally, and the talk will show itself, I would focus on PCT, Procalcitonin, and CRP, because evidently these are the two most widely used markers in terms of sepsis and/or infectious diseases. Next. So a few years ago, the international consensus was published by the European Society of Intensive Care Medicine, basically describing what sepsis means and what it is defined as. And simply put, sepsis is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to the infection. And once we go a step further and the patient becomes even more critical, where you have circulatory failure, then this is called septic shock. As we heard in the introductory videos, sepsis is a very big global health burden. It affects worldwide over 20 million persons. And in the US alone, over 900,000 people annually are affected by this syndrome. Next, please. So what are the major risk factors for developing sepsis? And this is from the American Family Physician website, which has been updated fairly recently. Of course, age is a big player, malnutrition, chronic illness, immunosuppression, recent surgery or hospitalization, indwelling devices, and then, of course, approximately 1/3 of sepsis cases occur in the post-operative period, which is, of course, a very big risk factor. Next, please. So if we look at the sepsis pathophysiology, what is actually happening? Of course, you need some trigger, and that trigger in this case may or may not be a bacterial product or a part of a bacterial structure, which will in turn start the whole immune cascade, which involves, among other players, the macrophage. And during this sequence of events, several things occur. You have activation of coagulation and complement system. You have degranulation, neutrophil activation, and also you will get disseminated coagulation, depending on what disease we're talking about. This is all mediated by different, let's say, reporter molecules, such as from prostaglandins or similar, and also through the liver, several intermediators such as IL-1, IL-6, which are all pro-inflammatory markers, are upregulated, and ultimately these will also stimulate the production of, amongst other things, CRP and PCT, which are the biomarkers that we actually and ultimately measure in the lab. Now, by itself, the body is just trying to contain this foreign object, but at the same time, because of an overreaction, let's call it an immunostorm, you end up also, in most cases, with endothelial damage, which ultimately leads to tissue injury and organ dysfunction. And of course, in accordance with the endothelial damage, you will have capillary leak, and also, which would also lead eventually to septic shock. Next. So then, if you want to be ahead of all these complications, because evidently you want to have some tools that are able to either detect these complications on time, or in any case tell you that there is an overreaction by the body, you would need some form of a biomarker which is easily measured and which can actually have certain, let's say, attributes. And I try to compile this from literature, also combining it to other well-known biomarkers, such as troponin, which has, been a golden biomarker in acute myocardial infarction. So what is an ideal biomarker in this setting? It is something that should discern infectious cause of sepsis, meaning is it bacterial or viral or even maybe fungal? Can it predict severity? So can you use it for risk assessment and therefore also guide your therapy, making it more or less intense? Monitor disease, of course, monitor the response to treatment, and you want to have something which is standardized and ideally non-invasive, meaning that with a simple capillary drop of blood or even a venous sample or even in urine, you will be able to measure this test in a standardized way. Why? Because at the end of the day, we want to use these test results and be able to compare them to other settings and in other countries which may or may not be using a similar test on a different platform. Should be robust and based on reliable platform. In this case also, you need this to be up and running all the time, because at the end of the day, these are tests that you perform in a stat situation, highly sensitive for early detection. You want to be there on time. And one of our slides that I'm going to show you later will show you why early detection is a hallmark in this particular setting. And of course, highly specific, because at the end of the day, you want to make sure that you're not looking at some aspecific or random bypasser. Accessible, we all are dealing with less and less financial possibilities, so we need to be using our money wisely in healthcare settings. And ideally, it should have a direct relationship between the amount of damage and concentration of the analyte. This you can use for risk stratification. For those of you that have followed the early years of BNP or NT-proBNP in terms of heart failure, this was one of the tests which you could clearly use to stratify how well or how bad the patient was doing. Next, please. So what are the traditional and newer biomarkers? And of course, we all grew up with the erythrocyte sedimentation rate. C-reactive protein has been around for many, many years. Bands and left shift, of course, whether you're doing that by an automated system or simply by doing a microscopic differentiation. Literature in the past has provided some insight into what a left shift may mean and what the added value of counting bands are or not. Interleukin 6, as I mentioned before, this is one of your intermediary markers which ultimately play a role in the upregulation of procalcitonin and CRP. LBP, lactate, and one which has come to my attention in the last couple of years, which is the neutrophil CD64 marker, which I will talk about at the end of my presentation. Next, please. So why is time factor so important? And this is derived from Radiometer. And if you look at this graph and you look at the left-hand side from my end, the sooner you start therapy to treat hypotension, and in this particular case also you start with effective antimicrobial administration, the higher your or the lower your mortality in this case, meaning that time is of the essence. You need to start as early as possible and know what you're treating, and the earlier you start, the higher the survival rate. And this is very critical because you can see in this graph, based on these studies, that if you wait even up to 12 hours with starting effective therapy, you will have a survival rate of only 20%. So that puts a lot of pressure on the biomarker that you are looking for or using that can help you actually discern the cause of infection/inflammation in the patient. Next, please. So if you look at this particular study that was provided by Meisner et al. A few years ago, this shows basically time release of several markers after a one-time bacterial challenge. And clear you can see that interleukin 6 and 10 and also TNF-alpha are the ones that rise the first within the 2 hours after the challenge. However, if you compare PCT, procalcitonin, to CRP, one can easily discern that CRP already starts to rise after 2 to 4 hours, whereas CRP shows a lag time of 8 to 12 hours. This is very important because one can imagine that you could use both of them if you want to be early enough, or in any case, you don't want to miss out on any possible bacterial presence. Next. So what I want to do following now with these markers is to ask and try and answer a couple of questions. Because we said earlier that we want to use an ideal biomarker, and you want to make sure, or at least have one that can help you together, of course, with your clinical insight, to help you distinguish whether we're talking about a bacterial or a viral infection. And we have some examples of community-acquired pneumonia or meningitis. Is it SIRS, so there's no infection, or is it really sepsis? Can you use these markers, whether it's CRP or PCT, for therapy guidance, and are they predictive? Next. This is a study published by Kamat et al. In Clinical Infectious Disease, and it's basically a meta-analysis looking at one particular disease, which is community-acquired pneumonia, and they asked themselves the following question. And in this particular case, they looked at PCT, procalcitonin in this case, and combined 8 studies in total, and we're looking at whether PCT, depending on what cutoff point you use, was able to distinguish between a viral or a bacterial cause. And the area under the curve that they obtained, combining these 8 studies, was of 0.73, and that for them was in any case a modest but fairly decent test that could help distinguish between a bacterial or a viral origin. Next, please. And then, in this other study by Gerdes et al., which published a meta-analysis in 1998, they combined 35 studies looking at the traditional CRP test, which is the one that most of us has been using for the longest time. And they concluded that although the majority of the others proposed using CRP as an additional tool for discriminating bacterial from viral meningitis, only negative CRP tests are highly informative in most clinical settings. And we will see some data on this in later slides. Yes? So a few years ago, 9 years ago, we here in Curaçao, in collaboration with Erasmus University, the Netherlands, embarked on a study of patients who were presenting to the emergency room department at the St. Elizabeth Hospital back then, and we simply asked the following questions. These patients came in and had febrile or high temperature ECI, and we asked whether CRP or procalcitonin was able to discern whether this came from a bacterial origin or, in this case, from a non-bacterial origin. And evidently, in this case, we used as our golden standard a positive blood culture. And if you look at the area under the curve, using the rock curve on your left-hand side, you could clearly see that the dashed line is the CRP area under the curve, which has an area under the curve close to 0.65, whereas clearly the procalcitonin, which is the thick closed line, showed a markedly higher area under the curve of 0.76. And our conclusion was that in this particular study, which was done with a small group of patients, around 80, procalcitonin was superior to CRP for distinguishing a bacterial origin from non-infectious origin in febrile patients. And again, this is in an Afro-Caribbean population setting. Next. So how about monitoring therapy? For those of you that have followed procalcitonin data in the last years, one of the first things that was said was that procalcitonin could be a very good, let's say, target to actually guide your antibiotic therapy. So I went ahead and looked in literature. How about CRP? Can you use CRP to guide your therapy? These two studies, which were published last year by Prince and the one below by Butler et al., showed that looking at different, of course, endpoints and looking at primarily patients that had exacerbations of COPD, that they concluded that when you were using CRP as a biomarker to guide your antibiotic treatment, that it would lead to either or a significant reduction in antibiotic treatment, and that there was no difference in mortality and or morbidity between the two groups that were analyzed, meaning groups that were guided by traditional protocols or groups that were CRP guided. Next, please. How about PCT? This is a large Cochrane database review that I found dating from 2017 that basically looked at over 6,700 participants in 26 trials in 12 different countries. And the endpoints that they were looking at was mortality at 30 days. And in this particular case, very interestingly, using procalcitonin to either continue or stop antibiotic treatment led to lower mortality in the procalcitonin arm versus the traditional arm. More so, regarding antibiotic exposure, participant in the procalcitonin guided group had a 2.4-day reduction in antibiotic exposure, which led, of course, to primarily lower antibiotic-related side effects and ultimately also to lower costs. Yes? So this is again another study just showing or trying to show whether you could use procalcitonin to differentiate between bacterial meningitis or viral meningitis. This is in relationship to the first few slides that I showed you earlier on. And again, the difficulty with these studies, even though they were showing very high sensitivity and specificity, is that most of these studies are using different cutoffs. So that is a point which also requires some attention when interpreting, of course, your whether or not you are going to use this cutoff that is in the package insert or a cutoff that you have to establish for your own setting. Next, please. In this particular study by Castelli, which was published in Critical Care in 2004, they looked at 3 markers, namely CRP, PCT, and also lactate, and tried to see if you could use these as stratifiers, meaning that can you see or is there a relationship between the procalcitonin or CMP concentration and whether the patient has a higher SOFA score, or a score that is indicating that the patient is faring less well or more critical. And in this particular case, clearly you can see for procalcitonin, using either SOFA scores or ACCP scores, that the higher the SOFA score, this is the top part of this slide, the higher the SOFA score, the higher the average concentration of procalcitonin. CRP did not show a very clear linear or semi-linear relationship. This study therefore confirmed earlier publications that procalcitonin shows a direct relationship between severity of the patient and its concentration. Next, please. Next. One of the questions that I asked earlier was, can you use either PCT, procalcitonin, or CRP to discern sepsis versus SIRS? And in this case, this was a study in a very controlled population of children undergoing coronary artery bypass graft, CABG. And in this very select group, what they did was they looked at both procalcitonin and CRP and split these up into two end diagnoses, whether these were SIRS or sepsis. If you look on your left-hand side, for me, if you look at procalcitonin and you compare SIRS to sepsis, two things are markedly visual. First of all, with SIRS, there is a modest elevation of procalcitonin post-op, but this goes back to pre-operation baseline levels. However, if the patient develops sepsis, one can see immediately that there is a substantial marked increase of procalcitonin, and this one drops steadily back to baseline after appropriate antibiotic treatment. So this is saying two things, basically, that one, procalcitonin can discern between sepsis and SIRS, that's number one, and number two, that there is a marked reaction of PCT to the antibiotic treatment. If we look at this particular group of patients and we compare the levels of CRP on the other hand, which is on your right-hand side, then one can say that it's very clear that the CRP concentrations have great overlap between SIRS or sepsis, depending on, and this is also head-to-head compared, whether it's days post-op or whether it's days after identification of a bacterial infect in case of sepsis. And also, when you look at day 3 after treatment with antibiotics, even though the mean of CRP was reduced, there is still a very great variation in measurements. Next. Just to touch base on lactate. What about lactate? Obviously, it is not a test that you use to distinguish bacterial sepsis versus viral versus SIRS. However, it has great monitoring value because at the end of the day, treatment goals are to bring back the lactate to lower than 2 millimole per liter. And we know from fairly recent studies that it has been accepted as a universally marker for worse outcomes during sepsis, especially in patients that end up at an ICU setting. Next, please. Now back to our reality. As we know, the world has been dealing with COVID for more or less the last year or so. So I decided to look up whether either CRP or procalcitonin can have an added value in patients that have been diagnosed with COVID-19. And in this study published by Luo et al. At the beginning of this year, using a cutoff value of 41.4 milligrams per liter, CRP exhibited sensitivity of 90.5% and specificity of 77.6% predictive value, and a negative predictive value of 95.4. And in this particular case, CRP was also an independent discriminator of severe critical illness on admission. They concluded, therefore, that in patients with COVID-19, admission CRP correlated with disease severity and tended to be a good predictor of adverse outcome. This is an important finding because this may mean that these patients may require earlier on more aggressive therapy to, in any case, dampen the immune response. Next. So how about procalcitonin? Does it have any prognostic value in COVID-19? This was published by Hu et al. Also earlier this year. If we look to the left-hand side, we will see that while looking at PCT concentrations in moderate patients, severe patients, and critical patients, you can see that there is a dose response of procalcitonin. More importantly, those patients that were discharged, meaning that they had full recovery, showed almost always a significant drop in the procalcitonin values as compared to the admission PCT values. This is the left part of your screen. And if you look at another subgroup, meaning this is a subgroup of patients that had an admission procalcitonin higher than 0.1 nanograms per milliliter, one can also see that every patient that was discharged showed a clear drop of PCT. On the other hand, if you look at cases that were included, which had mortality, procalcitonin did not show the serial drop in this case, but showed either a leveling of procalcitonin or a marked increase in the last measured value. So the conclusion of these authors was that both single and serial measurements of PCT correlate with severity of disease, and serial measurements predict adverse events. Next. Just briefly, I would like to touch base on neutrophil CD64, which is a fairly newer marker that came about 10 years ago. And this is basically a marker which becomes present on the surface of neutrophils after exposure to a pathogen, mainly bacteria. It rises within 2 hours, which is what you're looking for in a biomarker because of very, very quick dynamics. And it has been proposed in diagnostic monitoring and prognostic implications. However, the problem is that if you look at all the studies that were done with neutrophil CD64, all of them use different cutoff levels, complicating the evaluation of this test and how to implement it in day-to-day use. Furthermore, this is a test that is done on flow cytometers, requires several hours before you can actually have a result, so it's not easily automated as a CRP or a procalcitonin. Last but not least, neutrophil CD64, even though it rises rapidly, once you take away the bacterial trigger in this case, its levels remain elevated for 7 days, making it difficult for monitoring and follow-up of patients using this marker. Next. So again, these are some of the items that have been discussed earlier But again, neutrophil CD64 has not gained much acceptance simply because it's not standardized yet and very difficult to make as a, let's say, point of care or a rapid test. Next. So if you look at the various markers, and definitely I focused only on CRP and procalcitonin and slightly on neutrophil CD64, if you look at whether they discern cause of sepsis or not, I left PCT here on purpose empty, and there's a reason for that, because depending on what studies you look at and what settings you're looking at, definitely if you have very high levels of PCT, one can easily say with 100% that you are looking at a bacterial infect. If you compare it to CRP, PCT rises much earlier, and of course it's fairly easily measured, and both CRP and or procalcitonin have been shown that you can use them for either monitoring response, and also there is data that both can predict outcome. So the question remains, and this goes to my last slide, I believe. Next. What would be then the take-home messages? Which one will you be using, and how will you be using it? So we saw several markers that show good features, but none can be considered an ideal biomarker, the golden egg. Time is a very important factor. Therefore, early diagnosis and start of antibiotic treatment will improve outcomes. And in this case, we have seen that procalcitonin is a very good marker because it rises rapidly after an insult. Some studies suggest the use of a multi-marker approach. I did not use or show any data here, but there are studies that have combined CRP with procalcitonin and neutrophil count, and they have shown that when you use these combined, you will get a higher specificity and sensitivity. And maybe if I want to resume all these slides that I've shared with you, one can say that a high procalcitonin may signify a likely bacterial cause of sepsis, while the power of CRP lies in ruling out a bacterial infection. They both showed added value in reducing antibiotic therapy duration, which may lead to lower cost and fewer adverse effects. And with ongoing COVID-19 epidemic, both markers may serve as predictive tools, and numerous markers show promising results, but can only become relevant if they can be measured easily, rapidly, in a point-of-care setting and with relative low cost. With this, I would like to end my talk and would like to thank you for your attention.
Thank you very much, Dr. Ajubi, for your excellent presentation. And as I mentioned, you can type your questions and I will transfer them to our speakers at the end of the webinar. The organization of LabKnowledge will send you later today a link to fill the evaluation and the certificate of attendance. It's mandatory to fill in to get the certificate. Now, our next guest is Dr. Irakli Jaliashvili, who is qualified from Tbilisi State University in Georgia in 1980 in physics, and had his postgraduate training in Cardiology Research Center of Russian Academy of Medical Science in Moscow with a PhD in biochemistry. He joined the Mass Spectroscopy Center to the Tbilisi State University in 1980, and since then held a number of research positions in Georgia, Russia, and Denmark. During 1987 and 1989, he worked as a head of medical device department of the Ministry of Health of Georgia, and during 1992-1994 as deputy director, State Drug and Medical Devices Regulatory Agency, in charge of medical devices and clinical laboratory services. He joined the Radiometer Medical in 2000 as product specialist and since then provides clinical and application support to hospitals all around the world. Dr. Jaliashvili is going to present the conference Procalcitonin in Sepsis Management. Please welcome Dr. Jaliashvili.
Thank you very much for this nice introduction, and thanks for having me in your conference. It's a sepsis-related session, so we'll talk about the same sepsis-related stuff. I agree, it was very nice presentation from Dr. Ajubi, and probably I will touch the same area, same topics, but with a little bit different angle. I will try now to share my screen. Good. So basically, well, this is our standard disclaimer, so I think we can skip it quite quickly. We are saying that we are not liable for anything. So I want to cover 3 areas related to procalcitonin use in sepsis management. It's diagnosis, risk stratification, and guided management of antibiotic therapy. So, is it a real problem or not? It is. You can see here that in US only there are more cases of sepsis than combined number of lung, breast, and prostate cancer. And again, it's US statistics. It's 10th leading cause of death in the patients. So this slide, I was pleased that Dr. Ajubi said that it's a radiometer slide, but it's not. We are using it because it's very good illustration. This is a study done on, I think, around 3,000 patients, 2,700 patients in emergency rooms, and they looked on survival rate after onset of hypotension in septic shock patients. And as you can see here, basically every hour delay in treatment of septic shock gives you about 7.6% increased risk of mortality. This is well-documented study, and maybe at the end of presentation, if we have time, we can discuss other implications of this study. So let's say there are 2 questions hospitals have to answer. First of all, if they need procalcitonin or not. And if answer is yes, then how do they want to measure it? In a central lab or in point of care? And it's very good illustration how much time you may lose. There are some hospitals where central lab can give results very quickly, but generally 2-3 hours delay is normal versus point of care where you can get results in 15-20 minutes. So I think this slide serves well for this decision-making process. Dr. Ajubi mentioned third international consensus of sepsis and septic shock. And I want also to show a couple of slides regarding it because it changes, if we follow this definition, it changes diagnostic value of some biomarkers. In our case, it changed balance of weight between PCT and CRP. There's several, you can see that this is the third definition of sepsis, and now they're talking about another more accurate definition. One of the reasons why these definitions are changing is that, for example, second definition of sepsis, which we'll revert a little bit later, included SIRS instead of organ dysfunction, like in third definition. And this a little bit loose definition led to very different statistics in countries with comparable healthcare systems. I did not include this slide. I didn't want to make this presentation too long, but countries like Netherlands, Germany, Australia reported 20–40% difference in mortality due to septic shock because of this very wide definition. And you can see now sepsis and septic shock definitions. And if we try to put it graphically, so if we have infection only, or if we have organ dysfunction only, it's not a sepsis. These two conditions have to overlap, and then we have this sepsis area. So old and new definitions. In old definition, we had suspected infection and then SIRS. And in new definition, we again have suspected infection and SOFA scores. It can be full-scale SOFA. I will show you on next slide what does it mean, or it can be quick SOFA. So suspected infection, we have to detect by having some indications of infection. And we need also organ function indicators to which are derived from SOFA score. Septic shock in this situation is sepsis condition, which needs vasopressor therapy to elevate mean arterial pressure above 65, and if lactate is below about 2 millimoles after adequate fluid resuscitation. So it's more clear kind of definition. And this SOFA score, as you can see here, looks on different organs, coagulation, liver, cardiovascular, respiration. But as practice showed, very few hospitals used it. We can say other way that hospitals who were doing research in this area, they used it, but for regular patients, hospitals which are just treating, for them this was too complicated. And instead, quick SOFA score, sequential or sepsis related organ failure assessment was introduced. And basically this quick SOFA is easily done in every situation. So if respiratory rate is above 22, if we have signs of altered condition, or if systolic blood pressure is below 2 millimeters mercury. So when we are saying that increase of SOFA score by 2, at least 2 points, it means that at least 2 out of these 3 have to be fulfilled, and then we can talk about increase and sepsis criteria. So early diagnosis and rule out of sepsis. Gold standard remains microbial blood cultures. And I don't know, basically, maybe there are few hospitals in the world who can deliver results earlier than 24 hours. Meantime, you have to start treatment, and usually the empirical wide spectrum antibiotics prescribed, and then treatment is modified when you get microbiology results. So again, biomarkers like procalcitonin and CRP and others, which Dr. Ajubi mentioned earlier, they are not, of course, magic sticks which will solve the problems. They are just guides to help you to do clinical diagnosis. You saw this graph in Dr. Ajubi's presentation, and again, we are using it as well because it illustrates quite well onset time, which is around in some studies they say 2 hours, in some studies they are saying 3 to 6 hours for PCT, while CRP is slower. But important feature here is that half-life time of PCT is around 24 hours, so it reacts quite quickly to changes in patient condition, while CRP is more slow in this reaction. So PCT is clearly linked with bacterial infection and doesn't react on viral infections. Good negative predictive value, and PCT is not new parameter. It's quite well known and well studied, and there are many solid studies showing that we can have clear cutoff values, for example, for ruling out of sepsis. For example, if it's ED patient, values below 0.25 nanograms per milliliter is a cutoff value for ruling out. It's double of this in ICU. How we can use PCT in risk stratification? So we have two conditions to be present to call it sepsis. We have an organ failure and infection. Hemodynamic stabilization you can monitor by blood lactate, because stabilization is usually linked to good perfusion, and we know that lactate goes up when we have problems with perfusion. It's overall monitoring parameter. You cannot make any conclusion where you have perfusion problems based on lactate, but in a very simple terms, you have elevated lactate somewhere you are lacking oxygen supply, meaning perfusion. So for infection detection and control, you have blood cultures which are delayed because of nature of analysis, and you have procalcitonin, which you can get, as I told you, nowadays in 15-20 minutes after taking the blood sample. What makes procalcitonin good in risk stratification is that values correlate well with increasing severity of sepsis, as you can see on this graph. Now, lactate and procalcitonin levels together. This was a good study done, I think it's France, one of the Paris hospitals. They were measuring lactate and procalcitonin in emergency room, and they found out that they're complementing each other. So lactate levels above 2 millimoles and PCT above 0.8 were clear indications that patients had up to 60% mortality rate was reaching up to 60%, or patient had to be transferred directly to ICU. So they are good, they are well complementing each other, especially in ED patients, but also there are some studies showing that they have a good combined diagnostic value in ICU patients as well. So, in conclusion of this part, what we can say, PCT correlates well with severity of sepsis. Increasing levels support a bad prognosis. Decreasing levels support good prognosis. It reacts quite reasonably well time-wise. And PCT complements lactate in risk stratification. Now, antibiotic therapy, how we can use PCT in guided antibiotic therapy. This is a quote from Surviving Sepsis campaign, this latest guidelines from 2016. And what's the purpose of antibiotic stewardship? It's quite understandably. We have less resistant microorganisms, fewer side effects, and which is also very important, lower costs. It is quite well documented that if you follow your antibiotic treatments and you are guided with consecutive PCT measurements, you can shorten duration of antimicrobial therapy. Maybe not shortened, but optimized, let's call it this way, because in some patients, if you see by PCT levels that they aren't getting better, you'll probably continue. And also PCT levels can be used to support discontinuation of empiric antibiotics who initially were diagnosed or appeared to have a sepsis, but then proved to be healthy and not having sepsis. This is an interesting study done in ED in Switzerland, in Basel. And this here we have time to antibiotic discontinuation. And here we have a cumulative percent of patients. And as you can see, this red line is, red line is Procalcitonin guided group. And in average, I think it was 2.7 or 3 days. If I'm mistaken, it was in study. Earlier discontinuation of antibiotics with the same outcome in terms of mortality. So what is interesting here that in patients for whom antibiotics were withheld because on admission they had very low levels of lactate and procalcitonin, they were measuring procalcitonin every 6 to 24 hours. And in the patients with prescribed antibiotics, they were measuring every 4, 8, and I think it was 4, 6, and 8 days. So consecutive measurements of procalcitonin also have a very good diagnostic value. But in my opinion, most out of point of care measurement you will get in emergency room during the first measurement, because then if patient have a sepsis, every hour, every half an hour counts. The later, if patient is in a long-term treatment, it is not so critical and you can get the results from a central lab. This is the second good example. This is now in ICU settings. And that's how they use procalcitonin to reduce antibiotic use. And you can see here, this is red, is PCT group. It was, okay, it was in this study. It was on 19% less on antibiotic therapy than control group, with the same mortality and same outcome after 30 days. And in this particular study, they got 10% reduction of overall patient care cost in PCT groups, which sounds very good, but we have to be a little bit careful here in cost assessments, because they may prove to be quite specific to country, to hospital settings, what is share of antibiotic cost in overall patient care, and so on. So basically, that's what I wanted to share with you. I want to show you a couple of more slides. If you are interested in, today our topic is procalcitonin sepsis, but generally, if area of your interest is acute care testing, I would strongly recommend to, okay, it has to be org here. Okay, yeah, no. To visit this site. It's totally non-commercial, like our today's presentation. It's a compendium of short articles in different, related to different areas of acute care testing. And it's part of our Radiometer knowledge part. There is no registration, as far as I remember, no password. We have around, now probably around 550 different articles, adding every month, every 2 months, couple of them. And you can do a search. For example, if you type PCT, you can find articles related to PCT. And these articles are written by doctors and nurses or laboratory specialists from all around the world, like you in today's audience. So it's very good platform for sharing experience. And then, of course, you can either read or print or send or these articles. So that's it. Thank you very much.
Thank you very much, Dr. Jaliashvili, for your wonderful talk. And now we are going to have some time for discussion. I would like to remind you guys that you can type your questions in the chat room, and we can transfer them to our guest today. So I would like to say hi to our participants and friends from Barbados, Bonaire, Suriname, Curacao, and Brazil, which are connected right now with us in this live webinar session. So, well, I would like to open the discussion. I got a question for you too, and it's related about the proper use of procalcitonin. It has been controversial, as probably is happening in South America, also in the Caribbean. But what we see is that sometimes procalcitonin is used for some infectious diseases which we don't have enough data to say that it's useful. For instance, urinary tract infections, for instance, bone and joint, soft tissue infections. So what we understand is that procalcitonin may be helpful in respiratory tract and sepsis, but what happened with other type of infections? I would like to hear from you, your opinions. Thank you.
I would like to first give the word to Dr. Jaliashvili, and then I will give some comments.
Okay, I understand your concerns, and I can share my personal experience. It happened so that my wife with her parents-in-law and my son are temporarily, she was transferred with her job to US, and they are living in New York for last 2 years. So, and it happened so that both my father-in-law ended up in hospital with pneumonia, and my son in another hospital had some endoscopy procedure and then complications. So in my father-in-law's case, they did procalcitonin as usual kind of part of their tests. In my son's case, they prescribed very wide range antibiotics and did not do even CRP, although it was a university hospital. And when I asked the doctor who was treating him why they are not doing it, they told, we know about procalcitonin, but we don't believe in it. So it's very much still, despite procalcitonin is not a new parameter, very much still is believe, non-believe kind of area. But generally, I don't think that hospitals use it specifically for lung infections. So as soon as they had a suspicion on sepsis, the ones who are doing it, they are doing it. This latest sepsis definition, it's from 2016, but in many parts of the world, people may have heard about it, but they are not implementing it in their daily practice. So I think procalcitonin still needs some time to become as famous as CRP.
Thank you. Nasser, any comment about it?
Yes. When talking to the clinicians in our hospital, one of the things that I asked them was, why do you want to include, for instance, an ESR, erythrocyte sedimentation rate, in our stat package? And they said that that's the only marker they can use when you're looking at osteomyelitis. So something very localized, very deep tissue. So in such settings, I don't believe that, or at least I don't have any data that shows that you can use procalcitonin in that setting. Also, if there's a fungal infection, I've read mixed data on whether procalcitonin will or will not react to those to that setting or in that setting. So yes, there are some instances where you cannot use it, but like I said initially, it does have other very powerful virtues that you can use in more clear-cut situations.
Thank you very much. And I would like to get back to you, Nasser, and make a question about this neutrophil CD64 expression. And what about this biomarker? What do you think that will be the future with this biomarker? And if maybe you think that in the future it could replace procalcitonin at least?
Well, I think that your biggest challenge is always going to be how available is the test? Is it affordable? Is it easily automated? Can you transform it into a point of care setting, same as CRP nowadays, and also procalcitonin? But the future, and this is what I've been reading, not only for in settings of infectious disease or not, more and more people are talking about multi-marker approaches. So I would like to just encourage everyone to basically look at multi-marker studies that they've done, even though it will increase your cost, but it will definitely also increase your sensitivity and specificity if you are, have doubts on what's happening inside the patient.
Agree. Thank you very much. So other point that I would like to discuss with you is related the technical issues that we see with some methods for detect procalcitonin. What we see in Colombia is that some microlabs used to perform all those high throughput or high, performance methods, and others maybe are detecting procalcitonin even with immunochromatography or something like that. What do you think that should be improved to get good results and useful results of procalcitonin and even for CRP?
Doctor, I would like to give you the word first, and then I will give my thoughts.
Dr. Irakli.
Yep. Do I understand you correctly that are you talking about difference between central lab and point of care PCT measurement?
Sir, I'm speaking about the difference between the methods to detect procalcitonin, because there are different methods or different techniques to measure it. So what will be your recommendation to have, a good result and a useful result for clinical labs?
I think most widespread is immunochemistry, of course, like for other measurements, you always have a reference method, but they are usually complicated and difficult to run in ordinary hospitals. So as far as I know, most widespread is this or another version of immunochemical determination of PCT. Where I see there might be the problems is that nowadays we have a huge number of different manufacturers producing equipment for point of care. And sometimes I don't want to kind of talk about particular companies, but sometimes we see that they're compromising on quality of results, which is not acceptable. The fact that you are measuring quickly or closer to patient cannot be on cost of quality of results, because finally it will affect outcome. But I think leading companies, at least, they provide results with good accuracy and precision using immunochemical methods, different variations of. Yes,
thank you very much.
I would like to add something to that. Long time ago, when many diagnostic companies started to offer testing for hemoglobin A1C, if you remember, everybody was producing a different result. And one of the things that really helped bring down the variation between method and between lab is using very robust and worldwide, or in any case, recognized third-party controls, external quality assessment programs, which will help align the different methods. And again, one important factor will be, what is the traceability of the test? Is it comparable to the initial procalcitonin that was developed by Brahms? Do we have an international calibrator whichever company is using to standardize this test to? Once we get to those areas, irrespective on which method you use, at the end of the day, if you have a higher calibrator, that would bring the results closer together, and that will make it also easier to interpret all the different studies that we're looking at.
Yeah, but standardization in chemistry goes quite slowly.
Of course.
Many reasons. Some of them might be political, I don't know. But we are referring to Brahms method, and as far as I know, a few other very reputable manufacturers also referring to Brahms. And when you have this one method, it's good. Then you can kind of get along with it. But there are parameters where you don't have internationally recognized reference method or standardization, and then.
Thank you very much for your comments and your opinions about this subject. The last one, I would like to ask you about performing procalcitonin in other body fluids other than blood. For instance, CSF, or for instance, bronchoalveolar lavage or something like that. What do you think about that?
I don't have any experience with other fluids. We're focusing on blood and plasma. So, Nasser, Dr. Nasser, maybe.
I have found a few studies looking at other than blood body fluids. At the end of the day, as you know, procalcitonin is produced in many parts of the body, and depending on its size and depending on whether there's capillary leakage or not, you may find it in different settings. I believe that I have not seen enough data for it to be used. But of course, I do understand the need, because if you're specifically talking about, for instance, meningitis, you would like to see whether procalcitonin measured within the CSF might give you a better localized response than in blood. But I have not delved into that enough. It is something though worth looking at.
Thank you very much, Nasser. So thank you very much, you, Nasser and Irakli, for your wonderful talks. Thank you also to LabKnowledge and our sponsors to make this real, and let us share experiences in how handle sepsis diagnosis and treatment. I would like to remind you guys that the link for the questionnaire will appear on the screen, so you can click and sign up. Finally, I would like to thank the people behind the scenes: Neila, Emily, Harry, Daniela, Diana, Tishani. I hope I don't miss anyone, but I thank you very much for making this happen and real. I hope you have a nice day. We will meet again on October 21st for our next webinar of this Caribbean Antimicrobial Stewardship program. So have a nice day and please keep safe.
Bye-bye. Thanks for watching.
The Third Caribbean Antimicrobial Stewardship Conference is brought to you by Biomerrieux, Beckman Coulter, Radiometer, and Pharmenpex.